Hello, my name is Dr. DeGaston, and this is the Morning Report. Hello, my name is Dr. DeGaston, and this is the Morning Report. Today we have a case presentation of a 60-year-old man comes to the ER complaining of chest pain. It has lasted for 3 hours and it awoke him from his sleep. The patient has a history of obesity, hypertension, 40-pack years of smoking, and he also has high cholesterol in his history. He has a O2 saturation of 82% and a pulse rate of 116 beats per minute with a respiratory rate of 24. His blood pressure is also 169/96. Physical examination looks normal for the most part with normal heart sounds and clear breathing, but you do note an increased heart rate, respiratory rate, and he is diaphoretic. So let's think here. What is the most likely diagnosis and what labs and tests should be run right away? For me, looking at this, the first thing I'm thinking is acute myocardial infarction or a heart attack. And possibly it could just be angina where he hasn't yet had any infarction, which is dead heart tissue. We also need to think what other things might be going on, such as a aortic dissection or possible cardiac tamponade. And what labs and tests should we be running right away? We need to get EKG so we can check and see how his heart rhythm is doing, as well as get a chest x-ray to look at the size of the heart and size of the aorta behind it. Note in the EKG given that there is an elevation in leads V1 through V4. This usually will signify anterior or septal infarction within the heart. The patient will need to have a blood draw checking his troponin levels and consistent cardiac monitoring to check for any arrhythmias that may pop up. Also note in the x-ray on the right side that the lungs are clear and the cardiac silhouette is normal in size, showing no enlargement, and also the aortic knob at the top, right around this area, is not shown to be enlarging in any way, which reduces our suspicion but does not rule out an aortic dissection or cardiac tamponade. So a couple of suspicions here. We do suspect possibility of an acute MI or myocardial infarction. Basically, we think he's having a heart attack. We need to determine if the patient has the indications and, more important, contraindications for percutaneous coronary intervention, where a cardiologist will go in and stick a stent inside the arteries leading to the heart to make sure there's adequate blood flow, or thrombolytics, which is a drug that will dissolve all clots throughout the body. The second drug is known to be quite dangerous if not used correctly. And then also we need to quickly exclude other diagnostics that could mimic an acute heart attack, such as heartburn, and then there's also more severe situations such as an aortic dissection where the main artery out of the heart is being torn apart by high blood pressure. So what is our clinical approach to this? First, let's go over some definitions. Acute coronary syndrome, that is a spectrum of cardiac ischemia, including angina, which is a lack of oxygen to heart tissue, which causes pain, all the way to myocardial infarction or a heart attack where we actually have dead heart tissue due to a prolonged period of time without oxygen. This is usually seen with a thrombus formation in the coronary artery with previous atherosclerotic plaques or plaques building up inside the arteries, which get damaged over time. An acute myocardial infarction, to be an infarction, there has to be dead heart tissue. And there are two types. There is a STEMI. This is ST segment elevation that we see on the EKG, as was shown earlier, where the segment between the QRS complex and the T wave following it is elevated very high. The elevations must be seen in two concurrent leads. If it's only in one lead, you might just have a bad lead placement, and it has to be greater than a 0.1 millivolt elevation. And then NSTEMI is we don't see the ST segment elevation on the EKG like normal, but there is still dead cardiac tissue, and this is detected by doing lab work, such as looking at a person's troponin levels or CKMB, which are enzymes only found in heart tissue. So it should only be in the blood if there is dead heart tissue, which has a destroyed cell membrane, and then the proteins will leak out and detected in our lab work. A couple other definitions. Percutaneous coronary intervention. This is also known as stenting, angioplasty. Cardiologist goes in there and they open up the artery by putting a stent in. And then lastly, there's also thrombolytics. These are big gun drugs that will remove fibrin-based clots throughout the entire body and open up occluded arteries in the heart. Very high risk of internal bleeding because you might also have clots elsewhere in the body that are holding back blood from bleeding out of your arteries. For this reason, we actually go through an entire checklist, like have you had any recent brain injuries? Do you have a history of internal bleeding? Any major surgeries? We want to make sure we don't do any harm, and if you have a high risk of internal bleeding, we will not give you this medication. So what are some of the clinical manifestations of an acute coronary syndrome that's going to cause pain? Well, there is a atherosclerotic plaque, or a plaque in the arteries of the heart. If it occludes less than 70% of blood flow, then you're slightly obstructed and you're asymptomatic for the most part. Once you get obstruction greater than 70%, the blood flow is limited enough that you are going to feel pain during exertion. And then if the obstruction continues to grow, or if there is damage to the plaque in your artery, this is what can lead to unstable angina, where the plaque ruptures, your body's like, oh, there's a ruptured plaque, we need to fix it, and it actually builds up more of a clot on top of the plaque, and this is going to completely obstruct distal blood flow. And if this persists for a long time, you can get not just angina, which is pain, but you're also going to get a heart attack, which leads to dead heart tissue. The pathology behind it, I think, was pretty well explained. Most often the situation is you have a ruptured plaque in your arteries and your body tries to fix the ruptured plaque by clotting on top of it. But this clotting on top of it completely obstructs downstream blood flow and leads to deoxygenation of the heart tissues, causes pain, and eventually death of those tissues. Some additional causes that do come up but are much less common is you can have embolus, which is a foreign material that travels down the artery and at one point clots it. A coronary vasospasm, which is a signal sent to the artery correctly or most likely incorrectly, telling the artery to tense up really tight so no blood can flow through. And then a vasculitis or other inflammation that can obstruct flow of blood in the area. So what is some of the diagnostic criteria for a myocardial infarction? First off, chest pain. That's the cardinal feature. It's a heavy squeezing pressure. Feels like there's an elephant sitting on your chest and you're just feeling awful. Also, radiation of pain is common in the lower jaw, especially on the left side, neck, and left arm. Sweating and nausea are normal. There's also a sense of impending doom. And often ACS will also cause dyspnea, which is trouble breathing, and arrhythmias of the heart, which is trouble with your heart beating correctly and pumping blood. On physical exam, there is no specific physical findings to look for, but the history should definitely point you in the right direction. They'll be anxious, diaphoretic, or sweating, and then oftentimes you can hear a S4 or S3 gallop, which is an extra heart sound. Looking at the EKG, also known as a ECG, the earliest changes are tall positive hyperacute T waves afterwards, and then second of all, we'll see ST elevation in consecutive leads. If we see the ST elevation in consecutive leads, we know we have a heart attack going on here. Hours to days afterwards, we can often see the T wave invert, and instead of being a positive wave, it's a negative wave. And then finally, a diminished R wave in amplitude occurs over time. The most important thing about this slide, though, is actually different leads point to different areas and arteries of the heart that are most likely occluded, and I'll help guide the cardiologist to where should he go place a stent, and where should he first be inspecting. Lab work. There are two main labs that we order. In today's age, we mostly just order the troponin levels. It's elevated at 6 hours after the heart attack, and it'll be elevated for 7 to 10 days. So it's very easy to detect after 6 hours if they had a heart attack. Generally, two negative troponin labs will exclude the fact that they had a heart attack, and we'll chalk it up to angina, which is chest pain due to lack of oxygen, but you never actually are so deficient that some of the tissue dies off. A diagnosis of a heart attack includes two of the following. First off, chest pain persisting over 30 minutes. Typically, if they don't even report this one, we're not thinking along the lines of a heart attack unless there is the chest pain. Then the typical EKG findings, or ECG, will be noted in ST segment elevation in 2 consecutive leads, and then elevated cardiac biomarkers can help detect heart attacks in patients that have a normal EKG. So what is the treatment? Well, there's first the initial treatment and then the long-term treatment. The initial treatment is we want to make sure we obtain IV access. We want to get cardiac monitoring set up because if the patient starts to go into an arrhythmia and their heart isn't beating normally, we want to get on top of that immediately and give them antiarrhythmics to help their heart beat normally again. And then there's monotherapy, which is we want to give them chewable aspirin, and then morphine, oxygen, and nitroglycerin to help lower the pain and get more oxygen into the body. And then there's additional therapy to help save the cardiac myocytes, keep them from dying off. Beta blockers will reduce the demand for oxygen, and an anticoagulant such as heparin can reduce thrombus formation throughout the body. So you already have a clot there, but we're going to reduce it from forming bigger and stronger. And then definitive treatment consists of opening up the obstruction that is causing the pain. The most common thing is we want to stent it. Percutaneous coronary intervention does just this. A cardiologist will place a stent in the arteries leading to the heart to ensure adequate blood flow. If there's too many vessels obstructed, the patient will need bypass surgery. And that is, if you look in there and you're saying, hey, there's like 4 vessels that are obstructed, after you place a stent, the chances are downstream there might be another obstruction just waiting. And we won't detect it right away because we detect the upstream obstruction first and stent that. Also, thrombolytics, which is a big gun drug. It's a drug that will signal to the body dissolve clots throughout the body. It's very risky though, because those same clots that are causing problems in the heart, there may be other clots elsewhere in the body that are preventing internal bleeding, such as a post-surgery patient or a patient who has had head trauma or gotten a motor vehicle accident in the last 6 months. So here's a quick flow chart. I'm just going to go over it real quick. For a patient comes in with a heart attack, if you're at a hospital that can do stents, has a cardiologist available, then the goal is let's get the patient into the OR and get a stent placed in less than 90 minutes. If you're at a hospital, say you're in a rural area out in the boonies, and there is no cardiologist available to put stents in, well then we have a couple different options. First off, if we have a patient that is not a good candidate for thrombolysis because they've had recent head trauma or recent motor vehicle accident or surgery recently, absolutely do not send them in for thrombolysis. We can make the situation worse. It's much better to transfer them to a hospital where they can have stenting placed. Otherwise, follow the flowchart and determine if they are a good candidate for thrombolytics. Test it out. If it's a success, then you can still transfer to another hospital. If not, if it isn't a success, then you still need a transfer. Thrombolytics are never the end stage. You always need a transfer to a hospital where stenting can occur so you don't re-injure the plaque and cause more problems. Some of the main things for thrombolytic criteria on a good patient or not is, first off, if angioplasty is unavailable. If you can stent at the hospital you're at, do not use thrombolytics for a heart attack. Next, don't give it to patients in cardiogenic shock, because if they're already having low blood pressure from cardiogenic shock, you give the thrombolytics, it dissolves some clot, causes internal bleeding, you have a very tough situation. If they've had a heart attack within 2 to 6 hours or 12 hours with persistent pain, that's too early, or that's too late. We need to get them over for stenting. And then some absolute contraindications: prior head trauma, prior stroke within the last 3 months, known cerebral vascular lesion, known cancer in the brain, and a suspected or previous aortic dissection. Could just, if they've had a previous aortic dissection, the clot covering it could dissolve with the thrombolytics, and then you'll recreate another aortic dissection. Also note, we want constant cardiac monitoring, because if the patient goes into heart arrhythmia, these are potentially lethal and can kill the patient. Keep them monitored, make sure that they're not going to go into an arrhythmia that'll kill them. Also, heart block. Patients often can develop AV nodal heart block, especially with septal infarctions going on. So you need to know the different types and how to treat it if the occasion occurs. That isn't the main focus of what we're talking about. If a patient is in cardiogenic shock or pump failure, the heart's not pumping out enough blood, they have reduced ventricular filling, followed by reduced organ perfusion, such as the kidneys, the brain, the muscles throughout the body, extremities. With reduced organ perfusion, the cycle just gets worse as other organs aren't working correctly. Then the strain on the heart gets worse, which leads to then again less perfusion of the other organs, less oxygen everywhere, and this is a deadly cycle. In that case, we need to help the heart out. And to help the heart out, we're going to give additional fluids, typically saline. This is more long-term care. How are we going to look at risk stratification and determine the overall how we're going to treat them? A couple tests we might want to run is an exercise stress test. This is used to test for stable angina, commonly seen in patients who have had an acute myocardial infarction or heart attack in the past. And also an echocardiogram. This can be done to determine if the left ventricular function is incorrectly, if they have any valve problems going on, or also this is useful because it can detect things such as a cardiac tamponade or pericarditis after a heart attack. Long-term maintenance for the patient, we're going to talk about the drugs. After we've relieve the symptoms, we got to do risk modification. If the patient's smoking, definitely counsel them to stop. They should be on aspirin or another platelet antagonist. If the patient is using a drug-eluting stent, they will need both aspirin and something like clopidogrel. Statins also reduce the number of coronary events. They save lives. Beta blockers will reduce oxygen demand for myocardial tissue, and it also reduces cardiac remodeling, which and also saves lives and reduces the risk of things like congestive heart failure. And then ACE inhibitors are especially necessary in patients with diabetes because it will lower hypertension, it'll decrease injury to the kidney, and again, it also will reduce the cardiac remodeling by reducing hypertension and reducing afterload on the heart. Some clinical pearls. Acute coronary syndromes occur when a thrombus forms at the site of a ruptured plaque. Acute heart attacks are diagnosed with the presence of at least two of the three. The history has to show chest pain, a EKG showing ST elevation in at least 2 consecutive leads, or cardiac enzymes such as troponin levels are high. Once diagnosed, our goal is to save as much of the heart tissue as possible, give them either a stent, also known as PCI, or thrombolytics if PCI is unavailable. After a heart attack, PCI can still be done to reduce future symptoms and also reduce stable angina where you have an occlusion, kind of open up that occlusion from the plaque. And then long-term treatment should include diet, exercise, statins to help reduce our cholesterol, beta blockers, and ACE inhibitors. We also need to control blood sugar levels in our diabetic patients. Thank you and have a great day.
What was that? Also, why do a chest x-ray instead of a chest CT?
Cheaper, less radiation. I still don't know how to cancel this video and stop it. Brr.
I guess I'm just so used to work. They always do CTs.
Yeah, it's overdone.
Agreed. But we are a level 1 trauma center, so.
Oh my goodness.
Usually they only do an x-ray if it's not safe to move the person to a CT.